So good morning, everyone. I'm Polly. I am a lecturer at the School of Public Health. Good morning, everyone. Thank you, everyone, for joining our Zoom webinar. So today we are having a Coffee and Career series. So just a very brief introduction about this series. We will invite professionals from different public health and global health background, and where we will invite them to speak about their career, share their field experiences, share their career journey from time to time, and we hope that during this time you will be able to have an interactive conversation with some of our invited guests. So we are very lucky today to have Dr. Lincoln Lau. So let me just do a brief introduction. Sorry. Okay. So Dr. Lincoln Lau Lincoln, he is the Director of Research at International Care Ministries. He's also an assistant professor at University of Toronto. And so in terms of ICM, we just also want to give you a background of the work that Lincoln does. So ICM is a nonprofit organization that is dedicated to empower most socially and financially disadvantaged communities in the ultra poor communities. So that the work they do includes providing medical assistance, aid, education, preparing social welfare programs, and most importantly, the way that they deliver the program looks at how to maximize impact and also minimize the cost. So they're all about delivering the right support, the right training, the right resources with a goal to alleviate poverty. Okay. So before we get started, we have also Lincoln Live joining us. Are there any students that would like to introduce themselves and tell us about maybe a bit about who you are, why you're interested in public health and global health, or just maybe introduce yourself? So if anyone wants to share their thoughts or just introduce themselves, if you could just unmute yourself, and if you want to show your video so we can hear and see
you. Hear me?
Yes, we can hear you. Yes, go ahead.
Good morning. I'm a student from Beijing Sport University and major in kinesiology. I'm so interested in public health is because not only can do sports can do good to people's health, but we also need some technologies to provide more health care to those people who really need it. Okay, thank you.
Thank you for sharing. Does anyone else want to speak and introduce yourselves? Okay, I'm not getting anyone else. So, okay, we will just get started. So a brief overview of what we will be doing. We are aiming to finish this within an hour, and overall structure of it is that we have actually prepared a list of questions to ask Lincoln, and these areas of questions will focus on Lincoln's career, Lincoln's experience working in ICM, and also his experience right now, and also ICM experience dealing with COVID-19 and how that has impacted their work. And the last section that we're going to frame around the questions are just career advices, career journeys, and expectations. And then we will end off with the last section for opening the floor to questions from you. So if you have any questions, we are happy to have a Q&A at the end of the session. And again, if you can use the chat box, if you're not comfortable speaking, or if you just share your video and chat with us live, and that would be much more encouraged because it would be more of a conversation. Okay, so that's the structure of this hour. Okay, so we will just jump right in. So good morning, Lincoln.
Morning, Polly.
Good morning. Okay. Okay, so we will just get started. So, so our first question for Lincoln to share is, can you share your career and education journey and how you decided to pursue a career in public health?
Sure. Well, good morning, everyone, and thank you, Polly, for inviting me to speak and share a bit about what I've done. My career journey. So I did my undergraduate in biochemistry in Canada, and I think I was on the path looking at healthcare and medical science is something that I was interested in. So definitely, I was considering medical school, that I think that was the path that I thought I was going to take. When I graduated from my undergraduate, the first opportunity that opened up to me ended up being a internship in Bangladesh. So I moved to South Asia for 1 year, working with the Canadian Development Agency. And I was an intern that was based at a remote health project. I was 6 hours away from the capital in a small village that was trying to do a whole series of different interventions, but some work on maternal health, some work on savings, so social safety nets, and then some work on nutrition and a few things like that. And it was there that I think I got first introduced to the scope of some of the problems that communities face. And Bangladesh, if you don't know where it is, it's it's a country tucked right next to India on the eastern border. A huge country in terms of excluding city-states. It has the highest population density, or one of the highest population densities. And especially when I was there, extreme poverty was a big issue. So I won't go into too much detail, but there were a few experiences there that really gripped me as a person. And I had to really think about, there's a lot of people in the world that are struggling with simple things that I took for granted as I grew up in terms of health, and I wanted to chase something, at least gain skills to offer help. And it was the population level that really intrigued me. So from Bangladesh, actually where I ended up was Hong Kong U. So I did my MPhil and then straight to PhD at the School of Public Health. So I think some of you guys are students there. That was my educational journey. I ended up looking at infectious disease epidemiology, and I graduated in 2012. Following that, it was really, really helpful to get on the training, and then I went and did my postdoctorate fellowship at the University of Toronto. And that's when I also got connected with work in the Philippines. So I'm in the Philippines right now. I'm in Manila. And I started work here in probably around 2011, even before I finished my PhD. I had been looking at health interventions and trying to see if I can take those skills and add it to some of the problems here. So I'm sorry if that's a bit of a mouthful, but it's been a few different countries that I've had the opportunity to work in. And right now, my work involves looking after research programs and interventions that are happening here in country in the Philippines, as well as an office that we have in Uganda. So that's in sub-Saharan Africa.
Yep, thank you. I think our students would always be interested, how did someone get to their ultimate or current job, like the path to the career? So thank you for sharing that. When we're always talking about career, we're always talking about doing something that you love, finding a passion so that is your job and that is your career. Could you maybe share something or maybe things about what you love most about your job currently?
What do I love? That's a great question. I think it hasn't been easy, but I do try my best to keep one foot in the academic world. And so that's my connection right now with the University of Toronto, but also one foot firmly in the application side of the work. So sometimes that's one of the biggest tensions that I face. I'm sure most of you are aware, there's a lot of pressure to publish, and that takes a lot of time and a lot of effort, and it's incredibly difficult work. And then on the NGO side, actually the pressure is quite different. There's pressure to raise money, but there's also pressure to make sure that the programs are the best possible. And what I love about what I get to do is to try to keep one foot planted in both sides and to draw the absolute best from each side. So in academia, we have a high regard for data. We have a high regard for critical thinking, and strategic thinking is so important. And sometimes, just to be honest, that's lacking in the public health practice world that I see, especially with NGOs, and even more so in low and middle income countries. But then at the same time, I think sometimes academia gets criticized for being in an ivory tower and being removed, and sometimes writing papers that no one will read, or writing on topics that it just might be useful to publish, but cannot be applied in the field. So I think I'm been trying to live in both those worlds and take the best of both and apply it. So it means that I'm in all sorts of strange contexts, and I think I personally love that. I can be on the back of a motorcycle in a remote part of the Philippines visiting a TB patient one week, and then the next week I can be in a classroom talking about impact factors and research methods. But I love how those two worlds can intersect, and I really believe that there's so much that each world can offer to one another.
Mhm. It must be really challenging balancing between the world of academia and also your current work in SCM, GNGOs, but I think you're doing a wonderful job. So thank you for sharing with us. I guess we will move on to learning more about the work that you do in ICM. So your experience working in different cultures is so broad, especially now that you're based in the Philippines, which is obviously a very different context and culture from where you grew up in Toronto, Hong Kong. Could you maybe talk a little bit more about your experiences working with people across different cultures, and how has that impacted the way that you plan to implement programs or health programs in different contexts?
Sure. Yeah, so maybe it'll be helpful to talk a little bit about some of the work that I'm currently doing. So one of the persisting problems here in the Philippines is tuberculosis. The country, it looked like we were making a lot of progress in terms of the prevalence of TB in the country over time, but there was a recent prevalence survey that was done 2 years ago in Philippines. We found out the TB rate had not been going down at all. In fact, it might even have been going up in this country. So, on the low end, it's 0.5% of the population might have TB. On the high end, maybe 1%. So we're looking at maybe 1 million people with tuberculosis. So we had been trying to do all sorts of different interventions to try to get to the patients. And some of these patients, I think if you can imagine with me, it's not always in the city, not always in cities, not always at a specific address. Some of them live on the edge of a banana plantation or the edge of a pineapple plantation, or some are fishermen that live on stilts. And some of the places we go to, it takes 4.5 hours by ferry from the closest port. And there's just small settlements of people in all of these areas. And so the challenge is, how do we create programs that can really meet people where they are? And with that, I think thinking through how do we apply research on top of that to make sure that the programs are effective, that has been such a great learning experience and such an important learning experience. So I'm happy to share like one of the big failures that we had, or one of the big, it was a very sticky situation for us, but it was about 1.5 years ago. We were setting up an RCT, and we needed about 160 villages to participate. So we had the opportunity to bring together all of these different village leaders and these local community leaders, each representing their own community. And with a research assistant, we were trying to explain to them that we were inviting them to participate in a randomized controlled trial. And so I think most of you would know what an RCT is, but we put half of the communities or portion of the communities in the treatment arm, and then the other arm gets nothing. And we typically call that the control. So I was doing the training and talking to all of these community leaders, and I thought it went well. It was through a translator. And it was only about 2-3 months into the program that I was starting to get feedback that some of these leaders were upset. These leaders were not happy with what we were doing, and I had to have a few conversations, and it's difficult through a translator, but they were actually very offended by the word control. And so the leaders that got allocated to control kept saying, "Why are you trying to control us? Who do you think you are? These foreigners are controlling who I am, what I do, what my community gets. That's not fair, that's not right." And there's a lot of history here as well. This is a country that's been colonized many times. So for foreigners to come, put them in control, that was actually very upsetting, and she was quite offensive. And it makes me think again, okay, from a scientific in terms of scientific jargon, control group doesn't mean anything negative, right? I think most of us know if you get allocated to control group, it's just randomized. The computer generates the number, you get put into that group. But it just reminded me, we have to be so careful sometimes when we're thinking about applying and copying and pasting science into these settings, that we can't just take it for granted that people understand what we're saying. And so one of the biggest learnings that I have, I think I'm still making lots of mistakes, but is to really listen carefully. I think it's so important to have our ears open when we go into some of these settings, when the culture is different, the language is different, and to be very wary of the fact that it's really easy to cause misunderstanding, even if our intentions, are good on all sides. So that's been one, maybe it's just a small example, but I've found that having that posture of being willing to listen and learn, be very careful, is really important in this type of work.
Mhm. Yeah, I think, thank you for sharing that. I think whenever we're implementing any kind of programs or interventions, we really have to be reminded about who are we working with, what are the community, what are their needs, and we can't just translate what we assume or what we have been learning throughout our experience and then assuming that the other group is going to receive the receiving end. So I think Lincoln's sharing about his experience about working in different cultures and what needs to be reminded and for a maximized intervention is really important. So thank you for sharing that. I guess our next question, we will move on to the impact of COVID-19. So COVID-19 has been a worldwide experience phenomenon, and everyone has been impacted significantly. But I'm sure your team has much impact and experience about how your team has been coping with COVID-19 currently. Could you share a little bit about the experience and what has been going on so far?
Sure. I'm more than happy to share about that. So here, I'm sitting in Manila right now. Maybe there's some key differences that we're already starting to see in the response of the country to COVID-19. And one of them is that in kind of these emergency settings, it becomes quite clear which are the lower middle income countries, which are the lower income countries versus upper income countries. And the resources of the government and the ability of the government to organize, I think, it just becomes clear who has better control, who has better strategies, who has better resources. So as a country, early in the outbreak, when numbers were climbing all around this region, the Philippines was reporting 10 cases, 15 cases, and it just kind of stayed there. And I think what happens is that it creates a false sense of calm, that for a long period of time, the majority of the country just thought, okay, we're doing well. And lots of misconception around the fact that most likely there was lots of local transmission already. So I think the experience is very different from places that had testing capability and capacity. Instead here, everyone said things are okay, seems okay. And people weren't really worried, but it was strange because there was other people who would have travel history to the Philippines, go back to their home country and test positive for COVID-19. So all the evidence was saying that there's probably transmission here. We just wasn't testing, and we weren't testing much at that time. And then about a month ago, 33 days ago, I think, finally testing capacity started to catch up. Of course, this is a country that was probably lower down on the list in terms of priorities, lower down in the list of a country that would get test kits. And as you know, some of the kits come from Hong Kong and from Japan and from China and from other countries that have a lot more resources. And then so suddenly the cases spiked. And the cases spiked, I think, completely linked to the testing capability here. But what happens is that I think in a country where maybe there aren't as many epidemiologists, there aren't as many people in public health here thinking through the response, is that it feels like the government just went, okay, we went from completely calm and we're doing a good job to let's lock everything down. No one's allowed to leave their house. So I'm in an apartment building here. I'm not allowed to go outside to walk. I'm not allowed I'm not allowed to go jogging. The only reason to go outside is to buy food, and that's it. And I think in some places where the outbreak was very severe, that makes sense. But for here, it's very difficult to see how we can sustain this for a long time. So it has had major impact to the work that we're doing. Every province is deciding its own response. My team here, the ICM as an organization, we have 450 full-time staff, and most people are also stuck at home and locked down. But I think the biggest problem that we're seeing is that when we do such strict quarantine measures in a country where there's low resources, there are so many unintended consequences. And one of the big consequences that we're seeing is that there is widespread hunger in the country. Some of the communities that we work with, I think someone mentioned technology as being important. Yeah, even extreme poor communities have access to the internet, have access to Facebook, and they're telling us about how actually some of the communities we're working with haven't had a meal to eat in 6 to 7 days. So food security is just becoming a real issue, and I think the government is caught in an awkward situation where they want to look very proactive and deal very strongly against COVID-19, but the unintended consequence is, when a country doesn't have these infrastructure to support it, then we put a lot of the vulnerable population at risk.
Mm-hmm. Yeah, so I think you've also talked about how COVID-19 has been impacting in different communities, especially because now we're talking about people that are in vulnerable communities. They are in vulnerable populations, and that you can really see the impact between how the COVID-19 impacts people in poverty versus people in other countries and other income countries. So I think that is something that we all have to keep in mind. So in terms of how you see the impact in your future work, hopefully once that COVID-19 has been managed and contained, how do you see any impacts and how you would implement your future work in terms of health and poverty interventions based on your experience and what you've learned in COVID-19?
Sure. Yeah. So one thing that we are seeing, or one I think I was talking a little bit about it earlier, is that the cracks in the system become so apparent when crises like these happen. So I'm constantly in touch with Department of Health here in Manila right now, and I'm talking to a few different pulmonologists that are working in the front line, and they talk to me and they tell me these things that are actually quite worrisome. So here the healthcare system is a mix of private and public. There are some really expensive private hospitals. There are some not so expensive private hospitals. And then there's just a series of public hospitals in the mix. But what was scary to me is that there really isn't a referral system. So, you know, I think if we're looking at the Hong Kong as an example, a lot of the hospitals are in coordination with one another. And if one hospital gets overloaded, HA has the ability to look at bed allocations across the different hospitals that we have. And for the most part, doctors can know we can send a patient to the next hospital if we're completely overwhelmed. And there's communication between and coordination between these hospitals. Here, some of the big private hospitals, there was no coordination at all. So when it gets overflowed, what happens is the hospital just closes its door and tells patients, too bad, I'm sorry, that's it. And so we had, you know, announcements were coming out one at a time of one hospital saying, we're closing our doors to all patients, that's the end of our services, thank you very much. And then maybe 24 hours later, another hospital would post on Twitter, for example, and say that our hospital is closed. So part of what we're seeing is that this huge lack of coordination between tertiary care at the hospital level actually is pervasive. It matches what we're seeing in the primary care setting here and also in the community health work as well. So as I'm still working on tuberculosis, and I don't think that's going to change in the next few years, I'm thinking through a lot of how we really need to start to at least have proof of concept in some of the communities that we work in. How do we link healthcare services so that the burden is shared from community work all the way to tertiary work? And to think really strategically about sharing the burden across. and have a system have a small ecosystem where patients can be shared, and that expertise and capacity isn't just, concentrated in these isolated locations. So no, there's definitely lots that we're starting to see. There's lots that we're learning from how the healthcare system is responding to COVID-19 here, and the gaps that need to be filled just become so much more apparent.
Yeah, I don't think I can agree more with that, knowing that the gaps, maybe before COVID-19, maybe we're in different countries or different healthcare systems, we may not be aware that there is even that gap. But because of the impact of COVID-19, that gap and the challenges have just been tremendously just blown up. And then we really see what needs to be done more because of this COVID-19. So I agree.
Yeah.
Okay, so we will move on to our last section for Lincoln, asking him about career advices, because again, this is a career series where we want to engage students, be inspired. So, so Lincoln, what advices do you have for our current students or current participants that are maybe looking to work in similar fields or a similar path or that similar careers that you are taking?
Yeah. So loosely, I think the field that I'm working in right now is broadly sometimes talked about as global health. And I know there's lots of discussion about what is global health, what is it exactly, but let's not get into that here. But let's just say if working in mixed settings and issues like equity matter to you, and if part of whoever's on this call, if part of your aspirations is to work in these cross-cultural settings, difficult scenarios, and to creatively bring public health interventions to far and difficult to reach areas, some of the best advice I've gotten was from a professor who was based in Dhaka, in Bangladesh, and he was working at an institute called ICDDRB, which is the International Center for Diarrheal Research. He was a Johns Hopkins professor, and he just had this amazing project. It was funded by the Gates Foundation, and he was a respiratory doctor who had set up a clinic in a slum, in one of the big slums in Dhaka, in Bangladesh, and they were offering free healthcare to the whole slum, but at the same time they were collecting data. So he was running, I think he was actually running clinical trials in a slum, but at the same time providing high quality healthcare to the people they were serving. So I remember when I visited him, I was still a PhD student, and I remember asking this professor, how do you get here? How do you end up? I couldn't see the path from learning biostatistics, taking a biostatistics exam, or studying slides and learning research methods. How do you go from that to having a full functioning project in a slum in a foreign country that is both doing research and serving people that need help? And his advice to me was just, the skills that you need to do something like that successfully will never come from a single experience or from a course. You're going to have to go out and gain that experience. So he just kept encouraging me to, even if it seems like it's a sideways step, to keep moving. So I think I ended up getting involved in all sorts of different projects, but I felt that has really rounded out the skills that I need right now. Everything from negotiating with local government officials here. So now I can walk into a provincial government office and sit with a health official and have a good conversation that I might not have been able to before. But I've also worked a bit with microfinance projects. I've worked a bit with economists as well. I've worked with social scientists that focus on social networking and things like that. And I think that's the advice I would give to anyone else is the road to global health and global health work is almost never straight. I think that's pretty much, what we see is there's no stepwise progression into this field. It's going to be windy, and that's okay. And in a lot of ways, that's probably the best way to get into this field. Even if you feel like you're on a detour, I think I've found now more than ever that every single detour has helped me out so much more. And so, because of that, it gives me confidence. Actually, the work that we started in Uganda in sub-Saharan Africa just started 9 months ago, and we're opening a new office there. And I'm trying to coordinate it from Manila, but I think we can do it. And it's because I've done some projects in Kenya before, and I have friends in sub-Saharan Africa as well. So yeah, I think that's the advice is let the road be windy, no problem at all. Take a lot of detours, but a lot of times there's so many other skills we pick up along the way, even if it doesn't come under the umbrella of traditional public health training.
Thank you. I think it's very comforting to hear you say that, just that you don't expect to be a straight path, a linear path, and that all those detours and all those experiences in your life has brought you to where you are, and it has tremendous skills to assist you to go on to future projects. And I think it's also a helpful reminder to your students that as much as important having knowledge, having the theories and the concepts and background in with you, but transferable skills are also very important. How to work with others, how to communicate with others, how to work in teams and professionalism. And these makes you a well-rounded individual to whatever career path that you may want to pursue.
Yeah, and if there's one more thing, I think it really is important to do something you enjoy. I see that in this field, there are a lot of people, to be honest, there's a lot of people who get trained, especially in global health. If I look at the landscape of colleagues that I've met, people involved in disaster response, that's probably some of the harshest work. These are colleagues that I have who might be setting up sanitation for refugee camps. And I have colleagues who have been posted, everywhere from Greece recently with the Syrian refugee crisis, in Nepal with the earthquake that happened a few years ago. They were, some of them were actually in Indonesia after the big tsunami there, and they just go from humanitarian crisis to humanitarian crisis to humanitarian crisis. And a lot of times we talk about longevity in this field. If you really want to make a difference, but also have longevity in this field, there has to be this real passion for what they're doing, and just this excitement every time of going into the field. And I think there's people who will drop out, and there's no shame in dropping out from this as well. It's important to find that this is something that you can enjoy. This is something that you find meaning in, and then keep going down that path. But yeah, I think I'd be amiss to not also raise that there are portions of this that is very straining, and there are people that burn out. So it's also important to protect your own mental health as well.
Yeah, thank you. So our last question for Lincoln before we open the floor to Q&A from our participants is, could Lincoln maybe provide or summarize what are some of the key skills and competencies that you have come across by working with different people, from yourself, in different cross-cultural environment, based on in your different field work or your groundwork that has really helped their career?
Sure. Key skills. So I think we started off talking about listening, and maybe I'm just going to repeat myself a little bit here, but I think that posture of humility and being willing to learn and listen is really important. Let's see, I think a lot about the example of, because I'm working on tuberculosis, and I don't know if all of you know, but the first RCT in the world was on tuberculosis. It was streptomycin, and it was a randomized trial between patients that were just stuck on a bed versus stuck on a bed with streptomycin. So I think it was 1948, before 1950. And since 1950, we have come through all sorts of different development in tuberculosis, and some things have worked and some things haven't. And you would think that if the drug to cure tuberculosis was identified so long ago, why is it still such an entrenched problem in countries like the Philippines? And I think part of it is that the next big development in TB work was DOTS, which I think in the 90s, early 90s, was developed as this short course therapy and this strategy that was supposed to deal with TB. We have the drug, we have the strategy. Why isn't this working? And I can speak probably more to the specific context here, but the reality was trying to take a drug that requires daily observation, day after day after day after day, not for 5 days or 10 days. We're looking at 30 to 60 days, depending on the dosage. It just meant that it was impossible for people to follow. And not that, it was all failures, but I think for me, it's always an example of how, even though the science for a lot of it was discovered many, many years ago, to actually get it to work and to get this drug to be taken consistently until the end of the required treatment in these villages, in these fishing villages, in these slums, some people living in landfills or on the edge of a plantation, it does require even more creativity, and it requires even more thinking, and it requires, I think, a lot of listening. So yeah, I think I love the fact that 1948, someone, came up with the idea, let's do a randomized controlled trial. Back then it was brand new. Now it's not new at all. Now thousands of trials are being conducted. Maybe sometimes that's also what we need, is to come up with something brand new to bring the treatment even further along. So that's one thing, is I think listening. The second thing that I found very, very valuable in this field is flexibility. So you just have to be able to turn and to change and to creatively change what we're trying to do. Nothing I've seen here at the moment has gone according to plan. Almost every proposal that I write, when we actually try to implement it, it doesn't follow the timeline and it doesn't follow all the milestones. But we need to be okay with it. And then if there's one last thing, if there's a third thing, I think what I appreciate so much about graduate school is the opportunity to think critically. And from the US, he's a professor in economics, and he stressing to me that, even though we're from completely different fields, we are actually studying a method of inquiry. And that phrase has stuck with me quite a bit, is that all of you in graduate school, you are learning methods of inquiry, that when there's a problem, when there's a question, when there is an issue, we should have a toolkit to address these questions. And that toolkit, if it comes from a very strong method of inquiry, then it should give you so much more confidence that whatever you come up with is more grounded. Whatever you come up with isn't just floating in a vacuum, but the strategies, the designs, the ideas we come up with, as long as they're following a method of inquiry, then I think it puts you in a very good position to design programs that will be effective. So, yeah, those are just a few things.
Thank you for sharing the things that you found, or the key things that you found was really relevant and helpful to your career. Thank you. Okay, so that is the set of questions that we have prepared, or what I was going to ask Lincoln about his career, about ICM, and also his COVID-19, and also career advices. So in the last 20 minutes of this talk, we are going to open the floor to questions from you. Do you have any comments or questions, or maybe just want to talk to Lincoln about anything? We are very happy to hear you, and we would very like to hear your thoughts and your comments also. So again, if you would like, we would prefer that if you just unmute yourself or show your video, so then it could just be conversation. But in case you don't want to do that, you can also write your question in the chat, and then Lincoln and I would also be able to answer your question. So we will open the floor to any questions from our participants.
Thank you so much for Professor Lincoln and Polly Wong. And I have a specific question, is that what kind of specific jobs our public health students can do after they get a master's degree, you think, in this reality world?
Yeah, I mean, there's lots of different, there's a lot of different things you can look into. So some of my colleagues here that I get to work with would have explored things like internships with the WHO. We're lucky here in Manila that we have the Western Pacific Region office. We also have a country office. Those type of internships, I think, give great opportunity for people to get exposed to global health work. But I think there's also actually a lot of opportunities with local organizations, either NGOs or even research projects that are active and happening in global context. I think for me, sometimes the best projects are run by the busiest professors, and the busiest professors don't always have time to post job ads. So don't feel shy to just directly email and contact professors sometimes. If they've done a study that you're interested in, or they're working on a project that catches your eye and you want to do something similar, just go ahead and contact them. So yeah, I was talking about the Johns Hopkins professor that I visited in Bangladesh. I just looked him up and emailed him. It wasn't an official contact. He wasn't inviting anyone to visit him. I just directly wrote him myself and visited and just decided to do it. So yeah, I'd encourage you to just go out and look for opportunities like that. Yeah, the business people don't always have time to post job ads. So that's something.
Thank you.
My answer for Jana, hello, welcome to joining us. I think you really have to remind yourself, why public health? Like you asking this question because I assume that you are pursuing or going to pursue a degree in MPH, which is great. But just remind yourself, of all the degrees that you could choose, why did you choose MPH? Because that will bring back to what you want to do after you get your MPH. And we have to remind that MPH or public health is such a broad degree. There's so many areas that you can be working with. Like as in how Lincoln's work is, you could be doing interventions in community works, or you could be doing a consultancy, or you could be doing advisory, or if you want to be working into data analysis. So it really depends on what your key skills in and why you want to be in public health. And that would help you answer your question about, okay, after I get an MPH, what career can I have?
That's helped a lot. Thank you.
Yeah, okay, hope that answered your questions. Thank you.
Thank you.
Anyone else has any questions from the floor?
Hello.
Hello.
Hi. Thank you so much for sharing, Dr. Lau. I was very inspired by your experience working in Philippines because I'm pursuing the public health, focusing on the management and policy making side, and I saw there's a exchange program, I think in India and also I believe Sweden or Switzerland. So I know it is very challenging to work in like poverty countries such as Philippines and like Bangladesh. So I assume the challenge that if I decide to work in like more developed countries such as Switzerland, the challenges will be different. So I would just want to know whether you have experience working in a more like developed countries and what your thoughts on the challenges that they are facing, even though they have like a better technology, better system, but I think whether the system is is very complicated. It's because I think it's still quite a road for them to access the proper care as well. I don't know. I'm just like guessing. So I just wanted to know your thoughts on that matter.
Yeah, no, great question. So there's definitely challenges to working in resource limited settings. So I don't think I can say that there aren't. It always is difficult. And I think it's okay that it's difficult. So definitely if you go to somewhere like Switzerland or Sweden or any of the countries that have lots of resources, the skill set that you learn is going to be very rich and very, very helpful as well. So I don't downplay that at all. I actually think that technically you might be challenged in a very different way, maybe following the latest trends, working with researchers or professors or policymakers that are really maybe fine-tuning, tweaking a policy or a set of measures or whatever it is that have probably most likely been running for a while and have taken different twists and turns. So what I mean is, I think in a lot of high resource settings, the opportunities are to fine tune and to improve, maybe actually quite significantly, but most of the time my experience has been that things are already quite set up. So Just one example is, I might work with, in Toronto, I might do something small with Public Health Ontario, looking at immigrant health, which is something that I've helped out a little bit with. So looking at diabetes rates in recent immigrants that come from South Asia or into the place Canada. And it's a whole different type of project. We're looking at families that have immigrated to a new country, trying to change their diet maybe, but the health facilities, the health system, social services, they're all kind of functioning in Toronto and in Canada. So that challenge is very different. I think when you go to a place that's maybe like India, depending on which state or city you end up in, maybe all of that social support is not going to be there. Maybe your experience actually won't be to tweak something that's working 70 to 80% well. We want to make it now work 85% in efficiency or 90% efficiency. You might be dealing with a program that's at 15% of development. And so you can imagine that that's actually also a very, very different kind of experience. But yeah, I think it's very difficult to say one is better than the other, because I don't think there is. But there's definitely very, very rich learning if you're willing to put yourself in a place that's not easy to live in. Make sure that you're okay. Actually, mental health is one of the big issues for people in this industry. So if you're going to live in a foreign country, make sure you have things that you enjoy, checking your own mental health. But if it's something that you can endure, and maybe not even endure, you need to thrive in it, then I think there's lots that you can learn from that.
Perfect. Thank you so much.
Thank you, Zinyu. Any other questions from students?
Hello, can you hear me?
Yes, go ahead.
Hello. I'm Hillary, and now I'm a CME student, a year 4 student, and so I chose the MPH course for my master's studies, and I would like to ask a question. So, as Dr. Lau said, so mistakes may be made often during the process of practicing public health in developing countries like the Philippines or in Bangladesh. So I want to ask how to fix how to fix those mistakes, and I want to ask how to repair the relationship which is being damaged by those mistakes.
I think I got the second part of your question, which is to repair damage from the system. Could you quickly repeat your first question? I'm sorry, I didn't catch it.
Sorry?
Could you repeat the first question? I'm sorry, I don't think I fully heard it.
Okay. So I want to ask how to repair the broken relationships being made by those mistakes done before when you are practicing the public health practices in the developing countries like the Philippines or in Bangladesh.
Okay. Yeah. Oh, that's a great question. I think there is so much there. I think I understand your question, and I'll make a few assumptions, and I'm sorry if it's off. Broken relationships that I've seen, for example, here in the Philippines, as a country that's been colonized by the Spanish, by the Americans, and Japan also occupied this country for a while. There is actually a lot of damage that's been done, and there is a lot of suspicion from local Filipinos about foreigners and what their role should be in their country. And I think that's where it is really important to be listening carefully and to be very humble, because it's so easy to come into these contexts as another quote unquote expert, just because I have a degree from a foreign country, why should I have a stronger voice than someone here? And to be honest, a farm worker who's working on a banana plantation, for example, why is that person's voice less important than mine? And I think if we ever come in thinking that our voice is the most important voice, then we are really in danger of causing more distrust and causing more damage. So part one is really, maybe even if history is not your favorite subject, I think the historical context of each country is really important. Another example from Bangladesh. In Bangladesh, I think a lot of you might not know about it, but one of the big issues in recent history was safe drinking water. And then one of the big multilateral efforts was to dig wells around the whole country. So there was 2 water tables for a lot of the villages in Bangladesh, and there's a shallow water table. And so there's a lot of funding that came in from overseas. Shallow tube wells were set up across many, many villages in Bangladesh. And it was only 10 years later, 15 years later, that they found out that each of these wells were filled with arsenic. And so inadvertently, foreign aid had contributed to arsenic poisoning, and quite widespread arsenic poisoning in Bangladesh. So one of the projects I was working on was to test water wells, and we would paint them red if we would put big X's on them. People shouldn't drink with them anymore. But talking to some of the village ladies, they were telling me it took them 2 years. We told them, stop making your food out of the river water to use well water. That's what foreign aid told them. So they put in all these shallow wells. And then a couple of years later, now we come in and say, no, your well actually has arsenic. Now you need to buy a water filter, or now we need to dig you a 10 times more expensive deep well. And again, same thing. There is distrust, there's broken relationships, there's this idea that foreign aid has messed up, and why should they have to keep changing their life because this foreigner comes, this is bad for you. And I think, again, if you just come into that scenario and say, I don't really care, it was a very small thing. She was actually complaining that her curry tastes different. She finally fixed her recipe to match the tube wells flavor. And her old recipe matched the river's flavor, and now it needs to match the filter's flavor. And she was quite, adamant about that. And even though it seems like a small thing, I think it was just so important to let her speak that and to listen to her and to empathize that actually it is terrible, right? Why are these foreigners constantly changing your water source? And we should live up to the fact that foreign aid did cause a lot of, arsenic caused a lot of cancer in that population. Yeah, I think it's so important to know the context and to really be listening as we go into these scenarios.
Hi, Lincoln. So I have a chat question, so I'm gonna help read the question. Okay, so thank you, Dr. Lau, for the presentation. Apologies that I am at work and not able to speak up in the office. So we have a question from Perry. He is a research assistant in academia and have not been able to gain any research experience from NGOs yet. I suspect the challenges from doing research in academia and NGOs are very different. What is the biggest difference between research projects and academia and NGOs? What are the key skills these international NGOs are looking for when they're hiring? That's Perry's question.
Yeah, thank you, Perry. So you're definitely right. Academia work and NGO work is very different. And I think that there is, without being overly critical, I think there is a lot of times data is misused in the NGO world, and there is times when we act too quickly. To be honest, sometimes NGOs act quite decisively on anecdotes. And for those of us that have studied research methods and think about causality and think about association, a lot of times, 2 stories or 3 stories or 10 stories is not enough evidence for us to create action on it. But you'll find that NGOs sometimes end up doing that. So I would always be wary that if you're doing research with an NGO, is to know that if you're coming from academia, we are typically on the more careful side, and the amount of evidence needed to act is going to be much higher. And that's a really good thing to hold on to. So NGOs that don't have a research division or don't have much experience in that, I think, think carefully about how you want to push them to increase the evidence threshold that they need to make decisive action. But the other side of things is that sometimes I think through, I'm still trying to publish as well and write papers in peer-reviewed journals. And I think of the connection between a published article to somebody reading it, to then them putting that into their strategy or the plan, and then changing the way they run maybe a policy or an intervention or a clinic or whatever it is, that is going to take a lot of time. And maybe I'm just more impatient, but one of the pros of working in NGOs is we can shorten that cycle. The cycle from discovery to action can be compressed so that maybe even while it's being reviewed for peer review, or maybe we just send out some of our results to other colleagues that we trust and ask them to double check and to give us comments, and maybe we want to quickly act on it. So those are some of the differences. I think there's always going to be a tension because NGOs don't really exist for peer-reviewed articles and for presentations and for conferences. NGOs are really pushing sometimes to make maximum impact, to do it quickly, and it's kind of balancing those two out. The last thing you asked is, what are key skills that international NGOs are looking for? It is true. I think on the hiring side for international NGOs, most of the time they look for at least 1 or 2 overseas experiences. So they do want to see that you've worked in a different culture, and you haven't, and it's not something that you want to pursue. And I don't think it's, you shouldn't see it as like this rite of passage and people who work internationally are better or anything like that. But I sense that even for me, when I'm hiring, it's just, it gives me more, it decreases my risk knowing that someone has, maybe someone from Hong Kong has gone and lived in Kenya for 6 months and got through that period without quitting. It doesn't mean that you're much better, but it just means that, oh, then I think if you can do 6 months there, if you come to the Philippines, you won't pack up your bags in 2 weeks and also go home. So that's also something just to be aware of, is a lot of times international organizations are looking for people who just show that you can live overseas, and it's something that won't be too overwhelming.
Okay, thank you. So we have time for one final question. So do we have anyone that we can ask one more question?
Hi, Lincoln. Hi, Polly. I'll ask the final question if there's no other questions. So Lincoln, thank you so much for all your sharing. You do bring in a lot of your own experiences, just your unique experiences, cross-cutting both academic and also working in the NGO realm. And I guess to just wrap up this whole conversation that we're having right now, just want to really bring it back to your experience at ICM. Just because I'm really aware that ICM is a really large organization doing a lot of effective work. And a lot of that effective work is actually driven by data, driven by research, and driven by evidence, which is quite unique and one of the strengths of ICM. So I'm just wondering, perhaps from your experience with ICM working as a director of research, can you share about some examples or some experiences in which you've seen how data has effectively driven or informed some of your programmatic implementation or design? I think this is something that would be of interest to a lot of our students here and also to ourselves. Yeah.
Sure. Yeah, so I'm sorry that it feels like most of my examples right now are on tuberculosis, but it's just because that's what I've worked on a lot. I do have some examples from child malnutrition and high-risk pregnancies, but I think maybe the TB one will illustrate this the best. But yeah, let's see. So I think we talked about how a lot of the technology around TB has already been established, and there's still lots of push for new equipment, new lab equipment. There's actually digital X-rays now. There's lots of cool technology that's being built around TB. We're discussing with Fujifilm right now because they have artificial intelligence built into a handheld X-ray that can upload someone's chest x-ray, and it goes to artificial intelligence, and that, instead of going to a radiologist, we can get a result on suspected tuberculosis. So all of that's really, really, really cool. But at the same time, I was running a protocol through ICM here in the Philippines, where we were screening about 30 to 35,000 households a year for TB symptoms. And what we were doing is, everyone that was symptomatic at that time, we weren't linked to this high technology or anything. Anyone that was symptomatic, we were asking them to go to their the closest testing center and to get tested. And that's it. The first intervention was nothing. It was just, you see your symptoms, go to the closest testing site. And we ran this for about a year. I looked at it, came very, just that was something like 12 to 15%, depending on with different sites. And 26 different. So symptomatic people, I think percent, they don't want to get tested. So what we set up was a quick randomized trial of 4 different interventions to try to see if one of these things can assist people to get to cross the barrier or whatever is impeding them from getting tested. So we looked at food assistance, economic assistance, and then we put something else in called social assistance. And the whole project is actually kind of interesting. I think I felt that as a researcher, I don't want to be the one who chooses all the intervention. So we actually made it an idea contest for all of the frontline health workers that we work with. They submitted their ideas in, and then we used from the submissions what we thought were the best, the ones with the most potential, and that's what we randomized across all the sites that we work in. So the next year, we started looking at how each of these interventions helped. And surprisingly, and well, not surprisingly now, but what became very apparent was that while financial assistance, so helping a villager get from their remote location to the testing site is important, and it had a certain effect size. The effect size was significantly increased when we added social support. And social support wasn't too difficult. All it was we were subsidizing someone else in their village to travel with them, to sit with them in line, to hold their hand as they get tested. And when I think to it, I love the new technologies. Like, I think AI with X-ray is just such an important movement forward. But then we should also remember that they're human beings. And just because they're poor, it doesn't mean if you give them a coupon, they want to travel alone for an hour to go get tested for a disease with stigma. And giving them the opportunity to have their neighbor, their friend, their mom, their cousin, their uncle, to sit on the bus with them, sit on the motorcycle with them, sit with them in line, hold their hands as they get the results, maybe have a quick coffee before they go home. That aspect increased the efficacy of our intervention, was fantastic. So yeah, I hope that's a good example of how we ran a quick RCT, we randomized it differently, and it just showed there's this human element, there's a very human element to making some of these interventions work. And we can't forget that, that side of things. So tying good technology, good public health interventions, but not neglecting the social side. And then to have data to show that it's important was really, 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 really great. So.
Thank you so much, Lincoln. That was a great example. And I think that really sheds light, especially since it sheds light on the importance of acquiring good public health practice and skills in research design to be able to impact what people do on the field. And so thank you so much for sharing that, because that's just something that is very real and very practical. And I can see how our students and ourselves really appreciate you bringing that from the field to us. And so thank you so much.
Sure.
And with that, this will be a wrap up for our career discussion with Lincoln. On behalf of our team, School of Public Health, and also participants here, Lincoln, thank you so much for your time this morning, spent with us, talking with us, and sharing your experience with our students. We can't thank you enough. Thank you, Lincoln.
No, and all the best to all of you students. It's a real pleasure and a privilege to get to share.
Thank you. So for the rest of the participants, just wanted to thank also for your time for joining us this morning. We will continue to release career series and hope to give you experience and invite different professionals in public health and global health background. So please keep updated with us either in our Facebook page or email alerts, and we will be notified for the next career series. So that's a wrap up for today. Thank you everyone and have a great day. Stay safe and stay well. Thank you again, Lincoln.
Lincoln,
Oh.
it's Jan.
Oh.
I'm
Hi,
sorry
Jan.
I couldn't join earlier. I got tied up in another meeting. Thank you so much for coming and doing this. It's great. I'll take a listen afterwards because it's recorded.
Okay, no
Yeah,
problem.
hope to
Great to
see
hear your
Hope
voice,
to
Jan.
see you soon.
Sure. I'll let you know if
Lincoln.
I'm around.
Bye.
Bye. Thanks, everyone.
Bye everyone. All right. Bye everyone. Have a great day.
Thank you. Bye-bye.